Welcome to the session, What's New in Endometrial Cancer? We'd like to thank GSK for making this session possible. Cases of endometrial cancer are on the rise, but fortunately, this is also an exciting time for research in this area. We're joined today by Dr. Emily Ko, who is an associate professor at the University of Pennsylvania Perelman School of Medicine, Department of Obstetrics and Gynecology, in the Division of Gynecologic Oncology. And she has a particular interest in endometrial cancer. Additionally, she's a physician scientist with expertise in access and delivery of care, healthcare disparities, patient outcomes, health economics, and healthcare innovation. Thank you for joining us, Dr. Ko, and I'll turn it over to you.
Good morning. Thank you for joining us at the Ovarian Cancer Research Alliance 2023 National Annual Conference. For this session, I would like to talk about new treatments in endometrial cancer. My name is Dr. Emily Ko. I am an associate professor in gynecologic oncology at the University of Pennsylvania. These are my disclosures. None of the research funding specified here directly relates to the topic I will discuss today. For today's session, I'd like to provide an overview of endometrial cancer treatment. We will cover various topics including what is it and how common is it, signs and symptoms, evaluation and diagnosis, surgical treatment, staging and subtypes, precision medicine as it applies to endometrial cancer, post-surgical treatment, clinical trials, and opportunities to identify new treatments. Let's start off with epidemiology. What is endometrial cancer and how common is it? Endometrial cancer develops from the endometrium, which is the tissue lining the inside of the uterine cavity, as you can see in this diagram. Endometrial cancer comprises over 90% of all cancers of the uterus. Other types of uterine cancers include sarcomas, which arise from the muscular wall of the uterus. Endometrial cancer is quite common. It is the most common gynecologic cancer and the fourth most common cancer in women in the United States. Approximately 66,000 new cases are expected to be diagnosed in 2023, with approximately 13,000 related deaths. The average age of diagnosis is 60 years old. Approximately 3% of women will be diagnosed in their lifetime. And as you can see in this table, the 5-year survival for endometrial cancer is approximately 81%. And if the cancer is confined to the uterus, defined as local disease, survival is approximately 95%. If it is beyond the uterus, for example, located in the pelvis, regional disease, it's about 69%. And if it is located farther beyond, in terms of distant disease, then survival is lower. Endometrial cancer commonly occurs in menopause. As you can see from this graph, the vast majority of endometrial cancer cases occur in women aged 50s and 60s to 70s. Only 5% of endometrial cancer cases occur in women 44 years or younger. Endometrial cancer rates are increasing in the country. There's a rising incidence in the United States where more women are diagnosed with endometrial cancer each year. As you can see from this graph on the right, in the upper right corner, the curve goes upwards, as you can see there. And there's also a rising death rate in the United States as well. More women are dying of endometrial cancer each year, unfortunately. As you can see from this graph here, as depicted, the rate of deaths related to endometrial cancer is increasing. You can see from the red arrow pointing at the green triangles towards the bottom that the curve is actually uprising. And furthermore, endometrial cancer cases are increasing in non-white patients. As you can see from this graph, the blue circles represent the white population with endometrial cancer, and the other dots represent the other races. For example, you can see the blue triangles represent the Hispanic group that is uprising, and also the brown squares represent the non-Hispanic Black women. And you can see that line is rising as well, more steeply than that for the white population. And here again, you can see that endometrial cancer is more common in Black women with the bar graphs on the left. And more significantly, Black women with endometrial cancer are more likely to die from endometrial cancer compared to their counterparts, as you can see on this graph on the right, where non-Hispanic Black population has the highest death rate related to endometrial cancer, 9.1 over 100,000. And furthermore, stage at diagnosis. Black women are more likely to be diagnosed with advanced stage or higher stage at diagnosis, as you can see from the graphs here. On the left depicts all races, and on the right depicts non-Hispanic Blacks, where those diagnosed with regional disease and distant disease is higher at 20% and 17.5%, as you could see from the bar graphs. And interestingly, the more aggressive subtypes of endometrial cancer are increasing in the Black population. This has been shown as well with research studies. And you can see here with the various graphs, they demonstrate the different subtypes of endometrial cancer, including serous, clear cell, carcinosarcoma. And what you can see here with the brown squares, the line on all of these graphs depicts the Black population that are with the highest rates of these types of aggressive endometrial cancers. So what are the signs and symptoms of endometrial cancer? In general, abnormal bleeding is the most common sign of endometrial cancer. And with that, that definitely warrants evaluation and testing. Then, if endometrial cancer is confirmed, it then follows with treatment, usually via hysterectomy. And furthermore, after treatment, there is a surveillance or monitoring period. So what is abnormal bleeding? Abnormal bleeding is defined by frequency, regularity, duration, and volume. And that just refers to the pattern of the bleeding or the menstrual period each month. Perhaps the easiest way to think about it is to ask, do you have more than one period a month? If yes, that's a concern. Does your period last more than 1 week? And are you soaking through tampons and pads? If any of these answers are yes, then that warrants further evaluation. Additionally, postmenopausal bleeding is also a symptom of endometrial cancer. In the US, the average age of menopause is 51 years old. And how do you know if you've gone through menopause? If you have stopped having periods for 1 year, then that is the definition of menopause. And if you see the bleeding start up again, then that is concern and it is cause for evaluation. Approximately 2 to 30% of postmenopausal bleeding are associated with cancer. So knowledge is empowerment. If one has very long, heavy, or frequent periods, and any postmenopausal bleeding should be evaluated because they're the most common signs of endometrial cancer. Endometrial cancer can be fully treated, particularly if diagnosis occurs at an earlier stage in most cases. It is important to discuss the signs and symptoms of endometrial cancer with family and friends, and it is important to seek care from gynecologists and gynecologic oncologists in order to obtain the proper diagnosis and treatment. Now, what is the evaluation diagnosis of endometrial cancer? Generally speaking, pelvic ultrasound is a very good imaging study to look at the uterus and the associated parts, such as the ovaries. The endometrial stripe refers to the lining of the uterine cavity that we've been talking about, the endometrium. Pelvic ultrasound can be done via transabdominal or transvaginal approach, and transvaginal approach will likely give you more accurate information about the endometrial stripe. Ultrasound generally is not painful, and in general, endometrial stripe that is less than 5 millimeters is considered normal for a menopausal woman. Now, endometrial cancer diagnosis is made by obtaining a tissue sample of the endometrium. Let's keep in mind that a pap smear, which refers to scraping cells off the cervix, is not designed to detect endometrial cancer. A pap smear is designed to test for precancer or cancer of the cervix, which is a completely different thing. It is not related to endometrial cancer. How is the endometrial biopsy done? In general, it is performed in the office. There is no anesthesia that is required, and it is simply obtaining a small blind sample of the endometrial tissue. There's very low risk of infection, pain, bleeding, or injury to this procedure. And as you can see from the diagram here on the right, it's relatively simple. It just involves inserting a small, very tiny, soft plastic tube that's almost like a thin straw that's sterile into the uterus and collecting a small sample. And it is generally a very accurate form of being able to diagnose problems with the endometrium. Another method to diagnose endometrial cancer is by hysteroscopy, dilation, and curettage, also known as a DNC. This procedure is performed in the operating room, is generally done under anesthesia. And with this technique, using the hysteroscopy, which is placing a camera into the uterus, you can actually visualize the endometrial tissue directly. And then you can obtain either targeted biopsies, or you can use other instruments like a curettage to obtain a scraping or sample, a thorough sample of the endometrium. Once we have the tissue, it is sent to the pathologist and they will evaluate it. It often takes maybe about 1 week or more to get the report back. And on the report, there could be different entities. For example, endometrial hyperplasia is a precancerous condition in which the lining of the uterus is too thick. Frequently, the treatment for this condition is also hysterectomy in postmenopausal women, though treatment may also include medications such as progesterone-based or other hormonal medications in premenopausal women. Now, for today's talk, we're focusing on endometrial cancer. So again, that is cancer that originates from the endometrium or the tissue lining the cavity of the uterus. So if this diagnosis is made, what is the treatment? Here, we'll delve into the treatment of endometrial cancer. The treatment strategies for endometrial cancer are generally surgery or non-surgical. Now, to figure out which one is most appropriate for a patient, we have to determine what are the patient goals. Are we aiming for definitive treatment, or is there a concern to spare fertility in a younger patient? In general, the most definitive treatment for endometrial cancer is surgery, and that involves a hysterectomy because you're removing the source of the cancer. Now, of course, we have to ask, is the patient a surgical candidate? Are there other medical conditions that are related to this patient that puts them at increased surgical risk? We need to consider some preoperative testing to make sure they're an appropriate candidate, including blood work and sometimes imaging studies. And it is important to determine where the disease is located. And so this may involve different imaging studies, such as a pelvic ultrasound, occasionally a CT scan or MRI. If the disease is beyond the uterus, then we have to determine if it can be surgically removed. Now, talking about non-surgical or medical management strategies here, for example, it may refer to a younger patient who is still trying to preserve their uterus for fertility purposes. And in this case, then, hormonal or medication therapy may be used. We have to consider whether the risk of the medication, such as blood clots or nausea, intolerance, or weight gain. And for this type of management strategy, the patient would have to undergo repeated biopsies to see if the cancer clears. There's also a risk that the cancer may come back even if it does clear. And the success and failure rates are very important to be discussed by the provider with the patient. Now, the sequence of treatment standardly and most commonly, as discussed, is surgery first, usually with a hysterectomy, followed by possibly more therapy if needed. This may be chemo or radiation therapy, and then followed by surveillance, which is monitoring. If it is determined that cancer has spread beyond the uterus at the time of diagnosis, and this is, for example, by imaging studies, and it is determined that the patient is not a surgical candidate, then the approach may be to use chemotherapy or radiation first, and this is called neoadjuvant chemotherapy radiation, potentially followed by surgery, potentially followed by additional treatment to clear the disease. Now, what is a surgical staging procedure? This involves having surgery, mainly a hysterectomy to remove the uterus and cervix. It typically also involves doing a bilateral salpingo-oophorectomy, otherwise known as a BSO, which is removal of both tubes and ovaries. Now, it is important to assess also for any intra-abdominal disease. So the surgeon will look around the whole area of the abdomen and pelvis to see if there are any other areas that look abnormal. If they see tumor implants in the abdomen and pelvis, they will also biopsy and remove them. Additionally, it is important to see if the lymph nodes in the pelvic and periaortic area have any signs of metastatic disease. And there are surgical techniques we can use to do this. The most common now is sentinel lymph node biopsy, which I'll describe next. Other methods to evaluate the lymph nodes include a full lymph node dissection, which is more extensive, or lymph node sampling, which is just taking a few lymph nodes out. Surgery is typically done using a minimally invasive technique, either robotic assisted or laparoscopic assisted surgery. And this is a benefit to the patients because the incisions are small and it allows for quicker healing and lower complication rates. And it is safe for the treatment of endometrial cancer. Some cases may require open abdominal surgery. For example, if the uterus is too bulky or too large due to fibroids, to be able to be safely manipulated using a minimally invasive surgical technique. Now, sentinel lymph node biopsy, as mentioned, is a way that we can identify which lymph nodes are the best to remove, to test, to see if there's any spread of cancer. Sentinel lymph node biopsy has been standardly used for many, many years for treatment of breast cancer and melanoma, and now is applied to endometrial cancer for well over the past decade. It decreases operative time and morbidity. There are lower risks of complications such as infection, swelling of the legs called lymphedema, or collection of lymph fluid called lymphocele, or neuropathy. And how it's done is by using a dye, such as indocyanine green, ICG, that is injected into the cervix, as you can see from the diagram at the bottom. Then, using special cameras such as Da Vinci camera or SpyFi camera or other similar cameras, you can see where the dye lights up along the pelvic lymph vessels and the lymph nodes. Now, if a patient has a severe iodine allergy or liver failure, then we should not use ICG green dye. Alternatives can be Technetium 99 or isosulfan blue or methylene blue. And the surgeon is basically looking to see where the dye travels and which lymph nodes light up colored. Those are the lymph nodes to remove. Just because it lights up with a colored dye doesn't mean that the lymph node contains cancer cells. It just tells us those are the best lymph nodes to test for the pathologist to examine. And usually it involves removing just a few, 1, 2, 3, or 4 lymph nodes, and that is adequate to determine if there's any metastatic disease. Once the lymph nodes are removed with sentinel lymph node technique, then they're sent to the pathologist who perform something called ultrastaging. It's a way they can very carefully slice through the lymph node and put multiple samples under the microscope. Now, when they're looking at these slides, microscopic slides, they're looking for actually individual cancer cells that have traveled to the lymph nodes. And there's different words that you might see on the pathology report, such as macrometastases, where they're groups of malignant cells more than 2 millimeters, micrometastases, where it's 0.2 to 2 millimeters or greater than 200 cells, or isolated tumor cells, where clusters of cells not more than 0.2 millimeters are present. And they're present as either single tumor cells or clusters of less than 200 cells. Interestingly, ITCs does not necessarily upstage you to having pelvic nodal metastases. So even if you have just a couple of these cancer cells in the lymph nodes, when they're ITCs, it does not necessarily upstage you. Now, what we know from sentinel lymph node mapping research studies is that it is effective and safe. There have been many studies done and meta-analyses, which are basically grouping of all these research studies together that shows that it is very good to detecting metastatic lymph nodes. And the negative predictive value also is very high, meaning that if the test is negative, that the patient truly does not have metastatic disease. Now, the staging guidelines by the International Federation of Gynecologic Oncology, or FIGO 2023 guidelines, does state that sentinel lymph node biopsy can be used for all endometrial cancer cases, all types of endometrial cancer cases. So staging of endometrial cancer. Let's review what that is. Staging basically defines endometrial cancer prognostic groups, and it can be done through surgery or clinical staging. Surgical staging means undergoing a surgical procedure to obtain tissue samples from the abdominal pelvic cavity to determine where the cancer cells are located, if they're only inside the uterus versus if they traveled outside. And furthermore, to look at the specific microscopic features of the cancer cells. Here you can see on the diagram, stage 1 generally refers to the cancer cells being only in the uterus. Stage 2 refers to cancer cells traveling to the bottom portion of the uterus, including the cervix. Stage 3 depicts cancer cells that have traveled to areas also next to the uterus nearby in the pelvic area. And stage 4 generally refers to cancer cells that have traveled to other organs. Now, the staging system for endometrial cancer was updated very recently, as in 2023. So this is the newest staging system that was published by the International Federation of Gynecologic Oncology. It's known as the FIGO staging system. And stage is determined by both the location of the cancer cells as well as the features on the pathology report, such as lymphovascular invasion, whether the cancer cells have traveled into any blood or lymph vessels, the grade of the cancer cells, meaning how sort of severe or abnormal do they look under the microscope, histology, meaning what type or variant of cancer cells they may look like under the microscope, depth of invasion of the myometrium, meaning how deep do the cancer cells exist into the wall of the uterus, and micro or macro metastases to the lymph nodes. Now, we are moving into a new era of cancer care, and that includes precision medicine. How does precision medicine apply to endometrial cancer treatment? And what is precision medicine? So precision medicine is basically the concept that there's not a one-size-fits-all approach for cancer conditions, and that includes endometrial cancer. As we know, there are many subtypes of endometrial cancer, and these can be defined not only by how the cells look under the microscope, but what are the gene or molecular signatures of these different types of endometrial cancers. And with this information, we are better able to target endometrial cancer care. For example, using different types of drugs, such as immunotherapy. So what are the subtypes of endometrial cancer? There are a variety of subtypes, and the tumor type and genomic signature may be associated with cancer outcomes, such as prognosis and survival. And we're learning that specific treatments may be more effective for certain patients with endometrial cancer versus other. And it provides the opportunity to use more targeted therapies to tailor the treatment to each patient's cancer type. Let's review a few of these. Some types of endometrial cancer are hereditary. And these, for example, include Lynch syndrome and Cowden syndrome. Lynch syndrome is associated with gene mutations in these listed genes here in the table: MLH1, MSH2, MSH6, and PMS2. And the cancers that can be associated with these gene mutations include colorectal cancer, endometrial cancer, which are the two most common, as well as stomach, pancreas, ovarian, ureter, and kidneys. Lynch syndrome comprises approximately 5% of all endometrial cancer cases, so it isn't necessarily that common. However, it is important for families to know if that may be part of the picture. Cowden syndrome is another hereditary syndrome that is associated with endometrial cancer, and it is caused by the PTEN gene, which is a tumor suppressor gene. And with this condition, cancers associated with Cowden syndrome include breast, endometrial, colorectal, thyroid, kidney, and melanoma. By doing certain testing and having a conversation with a genetic counselor, it is possible to determine if a patient may be a carrier or may be affected by one of these genetic conditions. Now, in historic times, endometrial cancer was classified into a sort of two grouping category, type 1 and type 2. And generally speaking, type 1 was associated with endometrioid type endometrial cancer, and type 2 was associated with others, such as serous, clear cell, or carcinosarcoma. And this is what was thought of in the past, that type 1 typically applied to younger patients, typically more obese with diabetes or hypertension, less likely to have had childbearing, more often associated with white populations, and certain medical conditions such as polycystic ovarian syndrome, more associated with the Lynch syndrome, and more commonly found to have endometrioid type endometrial cancer with a better prognosis. Type 2, on the other hand, was thought to be more associated with older patients, less frequently with the obese or diabetic comorbidities, more frequently with African American Black patients, different type of gene mutations, and more often associated with the more aggressive subtypes of endometrial cancer, such as serous or clear cell, often with a more difficult prognosis. But what we're knowing now is that we're moving towards the era of precision medicine. And this was one of the groundbreaking studies. It was published in 2013. And this was taking a group of over 200 patients with endometrial cancer and classifying their cancer type by the gene signature genomic characterization, otherwise known as the TCGA. And here, what they did is they took all these patients and then profiled their gene signature. What they found, there were basically 4 groups: the POLE type endometrial cancer patients, the MSI or Lynch type cancer patients, the copy number low, or more likely endometrioid type, as well as the copy number high in the red box, which is more like the serous type endometrial cancer patients. What they found was that there is different survival associated with each of these 4 types, the POLE doing very well, and the copy number high or the serous type having the lowest survival, as you can see in the red line on the graph. And other areas or other medical institutions, including across the world, including Europe, also did similar, as you can see on the graph on the right. Again, 4 groupings, and they also looked at survival of endometrial cancer patients. They found similar patterns where if the patients were copy number high or P53 mutated in the red boxes with the red lines, they did have the worst survival. And those with the blue or the POLE mutations, as depicted by the blue lines, had the best survival. This has, again, been looked at with other groups of endometrial cancer patients, for example, in Europe, that were enrolled in a particular clinical trial called PORTEC-3. And what they did is, after the trial was completed, they looked at the type, a molecular type of cancer that the patients had. And again, when you broke them down into these 4 groupings, you found that it had reflected their survival. The POLE mutation patients did very well with the graph most on the left side. The P53 had the poor survival. The mismatch repair deficient, or MMRD, which are the Lynch syndrome-like cancers, did reasonably well. And the no specific mutation profile, the last graph on the right, also kind of did reasonably well. So what we're knowing is, based on this study, PORTEC-3, that genetic classification does relate to outcomes, and therefore it does affect how we want to treat the patients and monitor patients for recurrence. And again, this is just breaking the patients up into those 4 classifications that reviewed: P53 versus POLE versus MMR deficient versus no specific mutational profile, as you can see here. Now, this then led to our national guidelines for cancer care. The 2023 guidelines state that we should consider classifying patients into a molecular pathway. And this is the algorithm for doing so. So with an endometrial cancer case that is diagnosed, we want to identify if they have a POLE mutation. Not necessarily all labs in the country are able to test for this, but many are at this point. Further, if they don't have a POLE mutation, we want to identify if they have a mismatch repair deficient type of endometrial cancer, otherwise known as MSI high, MSI-H, as you can see at the bottom of the flow sheet. These are Lynch syndrome related type of cancers. And if not, then we want to see if they're copy number high versus copy number low, again, as reflecting the TCGA 4-group classification system. And what does this mean? Both the NCCN Cancer Network and the FIGO recommend testing a tissue to determine the type of endometrial cancer. Grade refers to the proportion of solid areas of the tumor, the extent of atypia, and range from grade 1 to 3. There are some histologic types of endometrial cancer that are known to be more aggressive, and these include the serous, clear cell, carcinosarcoma, undifferentiated carcinomas. The endometrioid type of endometrial cancer generally is thought to be a bit less aggressive, tend to be more low grade, grade 1 or 2, than grade 3. And lastly, molecular testing of endometrial cancer can provide prognostic information and is recommended by these large cancer organizations. So how do we treat endometrial cancer after surgery? Who needs chemotherapy and radiation? So this is defined, again, by determining what stage the patient has. So if it is stage 1 cancer, and there are certain features of the cancer which makes them more higher risk, which is depicted by the HIR, then it is recommended to have radiation. If they have particular subtypes, as we talked about, like serous, clear cell carcinosarcoma, then usually we recommend chemotherapy with or without radiation. If the cancer is stage 2, then usually we recommend radiation following surgery. And again, if there are certain subtypes of cancer, such as serous, clear cell, or carcinosarcoma, again, we recommend chemotherapy with or without radiation. And in general, for stage 3 and 4 patients, we recommend chemotherapy to follow surgical treatment. And here we can dive in a little bit deeper. These are the National Comprehensive Cancer Network guidelines. And here you can see that for endometrioid, subtype of endometrial cancer, that if it's purely a stage 1A, the earliest stage, and it's low grade, you don't need any treatment after surgery. However, beyond that, usually some type of treatment is recommended. That may be radiation in the form of vaginal brachytherapy or VBT, or when you get to the further stages, that may be radiation with chemo or chemotherapy with radiation. And as we talked about other subtypes of endometrial cancer, such as serous or clear cell, after having had surgery, then typically involve receiving some type of systemic therapy or chemotherapy with or without additional radiation. And for undifferentiated or dedifferentiated, which are potentially the most aggressive subtypes of endometrial cancer, after surgery, it is certainly recommended to have systemic therapy or some type of chemotherapy. Similarly, for carcinosarcoma, this principle applies. And what are the drugs that are used for chemotherapy? According to the most recent guidelines, they include paclitaxel and carboplatin and trastuzumab, otherwise also known as Herceptin. These are the drugs that are typically used in what we call frontline or the first line treatments for chemotherapy. Now, what are the drugs used if the cancer comes back? What we call recurrent cancer. So again, there are recommendations for drugs that best work for these cases. And these, again, do include paclitaxel and carboplatin. They do include trastuzumab, also known as Herceptin, and most recently pembrolizumab, also known as Keytruda, or lenvatinib, also known as Lenvima. And we'll dive deeper into these newer drugs. So as we're talking about precision medicine and that there are different types of endometrial cancer with different types of gene mutations, we can start to use drugs that are more targeted towards those mutations. For example, targeting HER2. This was shown with a phase 2 research study that enrolled women with stage 3 or 4 or recurrent HER2 serous endometrial cancer. And the women were either receiving paclitaxel and carboplatin with or without trastuzumab. They were comparing these two groups. And what they found was that women who did receive the trastuzumab had better survival, as you can see from the graphs on the right. Basically, those that received the trastuzumab drug, the green line, for example, had better survival than those that did not. And what they found was that the biggest benefit occurred in women with stage 3 to 4 cancers who are receiving trastuzumab for the first time. So that's depicted with the graph towards the right upper corner. So because of this study, trastuzumab has become part of the regimen for treating endometrial cancer. Now let's move towards immunotherapy. It is talked a lot these days about use of immunotherapy for endometrial cancer treatment. What is immunotherapy? It is a type of cancer treatment that uses the body's own immune system to prevent, eliminate, or control cancer. And there are different types of immunotherapy, including checkpoint inhibitors, targeted antibodies, cancer vaccine, and adaptive cell transfer. The most notable types of treatment for endometrial cancer has been with checkpoint inhibitors. And these are medications such as pembrolizumab and dostarlimab. And these medications are a monoclonal antibody that binds to the protein PD-1 that exists on the surface of immune T cells. It keeps the cancer cells from suppressing the immune system, which then allows the immune system to attack the cancer cells. So what we know is that immune therapy is effective for treating mismatch repair deficient endometrial cancer, essentially what we call Lynch type endometrial cancer. And there have been many studies that have shown this, initially starting with single agent studies in endometrial cancer patients that did show impressive response rates. As you can see here, the overall response rate, or ORR, ranged from 26 up to 57%. Additional studies have shown that using drugs such as pembrolizumab, which is immunotherapy drug, in combination with other drugs such as lenvatinib, improved survival in patients who had recurrent endometrial cancer. And this was shown with a very large study, national study in the US called Keynote 775. Here they compared women who had the pembrolizumab versus the classic paclitaxel carboplatin. And they found that in patients with advanced metastatic or recurrent endometrial cancer who had been previously treated with chemotherapy, that those receiving pembrolizumab and lenvatinib had better survival. And that's shown by these graphs that they had better progression-free survival, meaning the time to either recurrence, progression, or death was improved. And they had overall survival improvement shown, again, by the blue curves. So those receiving the immunotherapy agents had better survival, the blue curves being on top. So due to these large studies, immunotherapy was approved by FDA in 2021 for recurrent cancer. As you can see, these are very big headlines and really breakthroughs for the treatment of endometrial cancer. So that was in 2021 with the approval of pembrolizumab and lenvatinib. And then in 2022, FDA approved pembrolizumab as a solo agent for treatment of advanced endometrial cancer that is specifically mismatch repair deficient, or otherwise known as microsatellite instability high type endometrial cancers. And most recently, just in March of 2023, pembrolizumab was studied when it was used in combination with traditional chemotherapy in advanced endometrial cancer. This trial was called GY018. And this is a very big national study, enrolled over 800 patients, including those with stage 3 and 4 with measurable disease, as well as patients who had recurrent cancer. And with this, they were comparing patients who received paclitaxel and carboplatin versus those that received the combination of paclitaxel, carboplatin plus pembrolizumab. And what they found was that those that received the combination with pembrolizumab had improved survival benefit. And it was interesting, this was both in patients with mismatch repair deficient type of tumors, as well as those patients who were mismatch repair proficient, meaning they did not have that Lynch syndrome gene mutation. However, they still had a benefit with using pembrolizumab. And that's what you can see from the graphs on the right. And the biggest benefit was seen in the patients with mismatch repair deficient type cancers, where those with the top line, the survival curve is drastically improved. However, there is also benefit seen in the patients who had mismatch repair proficient type endometrial cancers, that there is still a benefit to receiving pembrolizumab. Again, as you can see from the top line of the graph that is in yellow, survival was improved, where the median progression-free survival, if you got pembro, was 13 months, compared to if you did not, was about 8 months. So we realize that pembrolizumab is generally very well tolerated. There are some side effects, most commonly, for example, fatigue, neuropathy, anemia, constipation, diarrhea. However, it is very well tolerated. Most patients were able to complete the course. And occasionally there's some rare, very serious side effects related to thyroid or bowels. However, this can be evaluated and generally managed by the treating physician. Now, Along the same lines, another drug within the immunotherapy family called dostarlimab was also studied simultaneously. And this was a very large clinical trial as well. And the results were simultaneously released in March of 2023 with the follow-up of the publication in the New England Journal, as you can see here. And again, this was a very, very large trial. And with this trial, the FDA also approved dostarlimab for the treatment of endometrial cancer. And as you can see, this was also very recently in July of 2023. So with this particular drug, it was studied in the RUBY trial. And with the RUBY trial is an international study, very, very large trial that enrolled patients stage 3 or 4 endometrial cancer that was not amenable to curative therapy. And these include stage 3A, 3B, 3C disease patients. Also included patients whose first recurrence had not been treated with systemic therapy or had been treated with neoadjuvant adjuvant systemic therapy and had recurred or progressed at least 6 months after they had completed their prior treatment. And what they were comparing, again, was similar to the GY018 in that they were having one group get paclitaxel carboplatin, and then the other group got the paclitaxel carboplatin plus the test drug, which is dostarlimab. And then they followed these patients up. And what they found is that the patients who received the dostarlimab had better long-term outcomes. And this was seen in both groups with the mismatch repair deficient type cancers, as well as the mismatch repair proficient type cancers. So the MMRP reflects the other bigger, vast majority group of endometrial cancer patients. And use of immunotherapy was beneficial for survival. As you can see with the blue lines on top, those are the folks that get dostarlimab, and they had improved survival. So what are the side effects? Again, dostarlimab was very well tolerated. There are some significant side effects such as fatigue, neuropathy, anemia, constipation. These are similar to the other GY018 trial that was mentioned. However, it still was very well tolerated. The discontinuation rate of dostarlimab was only 17% for the patients who received it on this clinical trial. So most patients were able to tolerate it and do well. And as a result, we now have these new immunotherapy drugs that are quite effective. And as a result of these 2 trials, they showed that immunotherapy is beneficial, including in the frontline treatment for endometrial cancer, meaning the first time that a patient gets any type of systemic therapy. Immunotherapy can be especially beneficial for patients with mismatch repair deficient type tumors. It can also be effective for mismatch repair proficient type tumors. And it is well tolerated when given in combination with paclitaxel and carboplatin. And clinical trials studying immunotherapy combined with radiation or other drugs are ongoing. So speaking just of a couple other treatment modalities, hormonal therapy is worth mentioning, and there have been improvements and advances in this space as well. For example, use of pills such as letrozole and everolimus, which are hormonally targeted agents, has shown to be beneficial. For example, there was a phase 2 trial that looked at the use of different combinations of hormonal therapy. One group got letrozole and everolimus. The other group got tamoxifen and medroxyprogesterone, different type of hormonal agents. And a total of 74 patients were enrolled. And what they found was that there was a quite high clinical benefit rate of those getting both letrozole, everolimus, as well as the tamoxifen, medroxyprogesterone. As you can see, 78% and 69%. And these were comparing the survival rates, progression-free survival on top, overall survival on the bottom figure, where you see the blue curve reflecting those that got everolimus letrozole, and the red getting the tamoxifen and medroxyprogesterone. What this is showing us is that there is benefit. There are other targeted therapies, such as hormonal agents, that may be particularly effective for certain subtypes of endometrial cancer if the tissue shows that they have these hormone receptors positive. Again, there are more studies underway in this space as well, including combining letrozole with other drugs and therapies. And then lastly, to speak of radiation, Radiation therapy can be a very useful tool in treating endometrial cancer, and there are different types of radiation therapy. One is vaginal brachytherapy, which refers to treating just generally the upper part of the vaginal canal, and that is most frequently used in some of our earlier stage cancers in conjunction with systemic therapy or sometimes alone. Another type of radiation therapy is external beam radiation therapy, which is a little bit more extensive, that covers more of the pelvic area, including where the pelvic lymph nodes are. And with this type of radiation therapy, there's a more advanced form of it called IMRT, intensely modulated radiation therapy, which uses multiple fields to shape the delivery of the radiation, which then better spares the bowel, the bone marrow, the bladder, and other organs, so there are less side effects. And currently, guidelines do recommend, when external beam radiation therapy is indicated, to consider using IMRT as the modality of therapy. Now, the newest forms of radiation therapy include stereotactic body radiation therapy. And this SBRT combines the IMRT technology with robust immobilization methods to ablate lesions down to millimeter accuracy inside the body. It can be used in areas that were previously radiated. And there are research studies underway to further study this use in endometrial cancer. And lastly, proton therapy is one of the newest forms of radiation therapy as well. Uses a different type of energy source, which is proton beam therapy, to better target tumor tissue. A few studies are available describing the use in endometrial cancer. However, it is still quite novel and generally is under study only currently. So, clinical trials. What is the purpose and role of participating in these? And what is a clinical trial? So, clinical trials are clinical research studies involving human participants assigned to an intervention in which the study is designed to evaluate the effect or effects of the intervention on the participant, and the effect being evaluated is a health-related biomedical or behavioral outcome. So, we have reviewed multiple clinical trials so far in this session. And clinical trials really are beneficial. They are the route through which we can identify new treatments for endometrial cancer. Where can one find clinical trials? There are different resources online, such as through the OCRA, Ovarian Cancer Research Alliance, of course, where you can find clinical trials through that website. And the most comprehensive repository of clinical trials is clinicaltrials.gov. Essentially, all clinical trials are to be registered through this clinicaltrials.gov platform. It is both used by researchers as well as patients, where you can put in keywords and search for clinical trials that are ongoing nationally and internationally for a particular medical condition, including endometrial cancer. Now, there are definitely opportunities for diversifying clinical trial participation. What we've seen is that there is there's underrepresentation of minority populations in gynecologic cancer research studies, specifically clinical trials. And this has been reported upon in several studies, that the observed Black enrollment was much, much lower than expected for ovarian cancer trials, for endometrial cancer trials, as well as for cervical cancer trials. And this is for various types of clinical trials, including the earliest, as well as such as phase 1 trials, as well as phase 2 and 3 trials. And so with this underrepresentation, it may be more difficult to generalize some of the prior research findings if we don't have a good representation of all types of patient participation in these clinical trials of all races. And this is an opportunity to have greater participation, therefore more generalizability to all patients with endometrial cancer. And this is just one example of an ongoing endometrial cancer clinical trial where precision medicine is coming into play. So here they are taking patients with endometrial cancer, but then dividing them into different molecular subtypes that we've been talking about. For example, the P53, the mismatch repair deficient, the non-specific mutation profile, and the POL-E. And once they're divided into these different groupings, they then receive, different therapies that would be most appropriate and are worthy of study to determine which therapy may be the best for these groupings or subgroups of patients. This is where we are going with precision medicine. So in terms of identifying new treatments for endometrial cancer, while we have made great strides, I think there is much opportunity for further discoveries. And what it does involve is partnership and advocacy. It does involve funding, and we are so grateful for all the funding sources that have supported this work. It does involve allowing access for all patients with all types of endometrial cancer to participate together. And it involves a lot of education awareness so that we can spread the knowledge regarding endometrial cancer so that we can ultimately improve our treatments and our survival for patients with endometrial cancer. It is, I think, very important that we have the opportunity to engage in a shared mission. And as we may have just seen, September is Gynecologic Cancer Awareness Month. There have been a lot of activities directed to this, including by the Foundation for Women's Cancer, as well as the OCRA, as well as other cancers, and we greatly appreciate that. And these are some websites that you could go to obtain more information. There are also various advocacy groups and patient-based groups, such as ICANA, which I like to highlight here, which is the Endometrial Cancer Action Network for African Americans. And again, it is a very useful community to be able to learn about the cancer and treatment opportunities and how to survive and help others with endometrial cancer. And research and funding are truly important because they help support the study of new drugs, delivery of care to specialized gynecologic cancer care, identify new treatments that are truly tailored to the individual cancer condition, also be able to truly identify treatments that are effective for underrepresented minorities and patient populations. And with this, we are hoping to advocate for more research funding to support the study of endometrial cancer. As you can see, endometrial cancer, as common as it is, receives much less funding compared to others such as ovarian, prostate, and breast cancer. And over time, the funding has not really increased. Even over the past decade. For endometrial cancer, it is still about the same at $14 million through the NIH, National Institutes of Health, compared to other types of cancer disease sites such as ovarian, prostate, or breast, where the funding has drastically increased. And I think this is where we can try to improve our support for endometrial cancer research. So in conclusion, endometrial cancer is the most common gynecologic cancer. There is a rising incidence or mortality of cancer cases, particularly affecting Black women and other racial minorities. Fortunately, there are newer drugs such as immunotherapy for patients that are newly diagnosed, as well as with recurrent endometrial cancer that have been shown to be effective. And molecular classification is driving current research drug studies in endometrial cancer. We see that endometrial cancer research has historically been underfunded, and this is an opportunity for improvement. And ultimately, let's mobilize a community of patients and providers to educate and advocate for endometrial cancer research and care. Thank you so much for the opportunity to provide this session on treatments for endometrial cancer.